Hi, this is Doc Ina, and I just want to share with you this lecture that I presented in March 7, 2020 during the Asian Hospital and Medical Center OB/GYN postgraduate course, and the topic is on menopausal hormone therapy in young cancer survivors. Now, different treatments such as surgery, radiotherapy, and chemotherapy for gynecological cancers may cause ovarian failure or increase menopausal symptoms. Due to advances in treatment, many young women with gynecological cancer survive long after their primary surgery. Now, oncologic care providers are increasingly recognizing that cancer treatment should also address female specific survivorship issues, and this includes menopause related adverse effects of cancer therapies or of natural menopause in survivors. Hot flashes are the most frequently reported menopausal symptoms, followed by insomnia, vaginal dryness, and dyspareunia. Systemic hormone replacement therapy, or HRT, is the most effective strategy in reducing menopausal symptoms among healthy women. However, many physicians are reluctant to prescribe HRT to survivors of gynecological cancers, regardless of exact tumor type and disease stage, because of the lack of international guidelines and, of course, the fear of medical litigation if a woman does go on to suffer a recurrence while taking HRT. Now, given that some types of cancer are hormone sensitive, there are safety concerns about the use of local hormone therapy among women who have uh, cancer or gynecologic cancer or have a history of gynecologic cancers. Now, for this lecture, we will only focus on some of the more common gynecologic cancers. This includes breast cancer, endometrial cancer, uterine sarcoma, ovarian cancer, cervical cancer, and vulvar and vaginal cancer. Counseling patients with or at high risk for cancer about treatment options for menopause should include a shared decision making approach employing principles of informed consent. The discussion about treatment options should include the mechanism of action if it's known, potential adverse effects, current data regarding efficacy and safety, and the benefits and risk of each treatment option. Clinicians should evaluate the woman's perceived need for treatment versus fears regarding cancer risk or recurrence risk. Additionally, consultation with the woman's oncology team is very important. And finally, when therapy is initiated, follow-up care should be arranged to ensure improvement in or resolution of symptoms and to assess compliance and barriers to treatment. Now let's first discuss breast cancer. Breast cancer is the most common invasive cancer among women, and in terms of cancer deaths is second only to lung cancer. The overall survival after a breast cancer diagnosis remains high, about 90%, and mortality has been declining over the last several decades. Breast cancer cells may express hormone receptors, including estrogen receptors and progesterone receptors. Various studies and laboratory data support a positive relationship between endogenous estrogens and the risk of breast cancer, with the proposed mechanism indicating increased cellular proliferation, decreased apoptosis, and DNA damage. Higher circulating estrogen levels in postmenopausal women have been linked to an increased risk of breast cancer in several prospective studies. Reproductive factors including early menarche, late age at menopause, nulliparity, and first pregnancy after 30 years contribute to higher lifetime exposure to estrogen and have been linked to a higher risk of breast cancers. Hormone receptor positive tumors make up the majority of invasive breast cancers, and reproductive and hormonal exposures are strongly linked to the development of HR or hormone receptor positive but not hormone receptor negative breast cancers. Now, in 1997, there were two landmark independent randomized clinical trials. That's the Habits trial here in the left and the Stockholm trial here in the right. And these landmark trials were initiated in Sweden. to compare menopausal hormone therapy with no menopausal hormone therapy after the diagnosis of early stage breast cancer. Now, much of the design of both studies were similar. However, a goal of the Stockholm Protocol, which is not shared with the habits trial, was to minimize the use of progestogen combined with estrogen. The habits trial was prematurely stopped in December of 2003 because at a median follow-up of 2.1 years, the risk of recurrence of breast cancer among patients who received menopausal hormone therapy was statistically significantly higher, with a relative hazard of 3.3, than among those receiving no treatment. Now, compare that with the Stockholm trial, which showed that after 10.8 years of follow-up, there was no significant difference in new breast cancer events. Now, this is a very nice summary or a table showing to us the summary of the habits in the Stockholm trial. And as I've said, the habits trial showed a significant difference between the two treatment arms, whereas the Stockholm trial, which had a longer median follow-up of 10.8 years, showed no significant difference between the two treatment arms. Now, let's see some newer literature or evidence regarding the effect of HRT among breast cancer survivors. Now, this is a systematic review which looked into the impact of hormone replacement therapy among premenopausal breast cancer survivors. And the results showed that the meta-analysis of breast cancer recurrence in the observational studies showed no significant association was found between the HRT and the risk of recurrence of breast cancer. However, the randomized control trial found an increased risk of recurrence with HRT among women less than 50 years old. And so the conclusion of this systematic review is that among or the HRT or the use of HRT in breast cancer survivors less than 50 years old revealed conflicting results between randomized and observational study data. And so further studies are warranted to investigate this association. Now, what pearls do we have regarding the use of MHT among breast cancer survivors? So, after all these studies have shown evidence, menopausal hormone therapy is not recommended for use in breast cancer survivors given the increased risk of cancer recurrence, and non-hormonal options for treatment of menopausal symptoms are advised. Non-hormonal approaches are the first-line choices for managing urogenital symptoms or atrophy-related urinary symptoms experienced by women during or after treatment of breast cancer. And among women with a history of estrogen-dependent breast cancer who are experiencing urogenital symptoms, vaginal estrogen should be reserved only for those patients who are unresponsive to non-hormonal remedies. Now, again, this is a very nice table showing to us the summary of those women who are eligible for local hormone therapy or vaginal hormone therapy. And usually these are patients who have early stage breast cancer or have a history of early stage breast cancer. The grade of disease should be low or intermediate grade. There's no lymph node involvement. There's negative hormone receptor status. There's low risk of recurrence, and there's a remote time since diagnosis, and the symptoms are very severe. And of course, as I've already mentioned, this local hormone therapy should only be offered for patients who are unresponsive to the non-hormonal therapy. Now, what are this local hormone therapy that we're talking about? This usually comes in the form of a vaginal cream, vaginal ring, or vaginal tablet. Now, here in the Philippines, we have a vaginal cream with a brand name of Ovistine, and the vaginal tablet comes in with a brand name of Vagifem. So here's a nicer table showing to us the product names or the brand names for each vaginal hormone preparation, and the initial and maintenance dose. Now we move on to endometrial cancer and uterine sarcoma. Endometrial cancer is the fourth most common cancer, and type 1 endometrial cancer is the most common subtype, and it typically has endometrioid histology, is positive for estrogen receptor and progesterone receptor, and is hormone dependent. Type 2, on the other hand, typically lacks hormone receptors, is not hormone dependent, and most commonly occurs in postmenopausal women. It commonly has serous papillary histology and is often higher grade and aggressive. Now, most studies on MHT after endometrial cancer treatment have been conducted among women with type 1 endometrial cancers. Like breast cancer, endometrial cancer can be hormone responsive, and both cancer types are adversely impacted by high levels of endogenous estrogen. The incidence of endometrial cancer is increased in the setting of unopposed estrogen but decreased with estrogen plus progestin. Observational studies have consistently found an increased risk of endometrial cancer incidence with estrogen therapy alone. Both estrogen receptor and progesterone receptor have been identified in malignant endometrial neoplasms, and the loss of expression of estrogen receptor, progesterone receptor A and B have been associated with poorer survival in women with endometrial cancer. In early stage disease, the presence of progesterone receptor is the single most important predictor of 3-year survival. And there's also the theoretical possibility that estrogen may stimulate occult cancer cells. Now, here's a Cochrane meta-analysis that looked into the hormone replacement treatment for women who are previously treated for endometrial cancer. And this meta-analysis concluded the following. There is insufficient high-quality evidence to inform women considering HRT after treatment for endometrial cancer, and the available evidence does not suggest significant harm if HRT is used after surgical treatment for early-stage endometrial cancer. There's no information available regarding use of HRT in higher stage endometrial cancer, and the use of HRT after endometrial cancer treatment should be individualized, taking account of the woman's symptoms and preferences and the uncertainty of evidence for and against HRT use. Now, this is a very new systematic review that was published very recently, February 2020, that looked into the effect of HRT among endometrial cancer survivors, and it concluded that HRT use had no negative effect on prognosis of endometrial cancer survivors in tumor stages 1 and 2. Now, here are the clinical pearls that we learned regarding the MHT use after endometrial cancer. So, there's limited data that suggests that women with low grade and early stage type 1 endometrial cancer may consider MHT as indicated. However, MHT may stimulate tumor growth in patients with more advanced disease, and for this cohort of patients, non-hormonal approaches to management are recommended. And there are insufficient data to inform decision making in the setting of type 2 endometrial cancers. The use of hormone therapy may be considered in symptomatic women with surgically treated early stage endometrial cancer if other options are not effective, particularly among women with early surgical menopause who are at higher risk of health consequences related to estrogen loss. And non-hormone therapies are recommended for women with more advanced cancer or higher risk endometrial cancer. How about uterine sarcoma? Uterine sarcomas include leiomyosarcomas, carcinosarcomas, adenosarcomas, and endometrial stromal sarcomas. Endometrial stromal sarcomas overexpress estrogen and progesterone receptors, and estrogen, HRT, and tamoxifen were reported to have an adverse effect on the disease outcome, and therefore HRT in these tumors should therefore be avoided. For leiomyosarcomas, the removal of the ovaries during hysterectomy did not improve the 5-year overall survival rate, and this may indicate that leiomyosarcoma is not hormone sensitive, and HRT may therefore be given, as suggested by some authors. In carcinosarcomas and adenosarcomas, HRT can be safely used. So, as a clinical pearl regarding the MHT use after uterine sarcoma, among uterine sarcomas, only endometrial stromal sarcomas are considered to be estrogen dependent, and HRT should be avoided. Now let's move on to ovarian cancer. Ovarian cancer is the fifth leading cause of cancer-related death in women and the deadliest of the gynecologic cancers, with an overall 5-year survival rate of only 45%. Epithelial ovarian cancer is the most common type of ovarian cancer. Now, germ cell tumors are usually seen among girls and young women aged 10 to 30 years old and are often treated with unilateral oophorectomy and chemotherapy. For borderline ovarian tumors, these are an independent entity and they account for about 10 to 20% of epithelial ovarian neoplasms. Endometrial epithelial ovarian cancers are very hormone sensitive, and the development of this histologic subtype has been linked to both endogenous and exogenous hyperestrogenism. Sex cord tumors are thought to be hormonally active also and often present with signs of hyperestrogenism. The specific pathways of carcinogenesis for non-hereditary epithelial ovarian cancer is still unclear. Now, here is a meta-analysis that looked into the post-op HRT use for epithelial ovarian cancer patients or epithelial ovarian cancer survivors. And this study or meta-analysis concluded that for EOC or epithelial ovarian cancer patients, post-op HRT does not have a negative effect on overall survival and tumor recurrence. This is a randomized control trial that looked into the use of adjuvant hormone therapy for epithelial ovarian cancer patients, and it concluded that women who have severe menopausal symptoms after ovarian cancer treatment can safely take HRT, and this may, in fact, infer benefits in terms of overall survival, in addition to known advantages in terms of quality of life. And the EPIC cohort study showed that there is significant survival advantage identified in long-term MHT users versus never users among patients with epithelial ovarian cancer. Now, here's another meta-analysis that looked into the hormone therapy effect for ovarian cancer survivors, and it showed that disease recurrence rates did not differ between the two groups or the two treatment arms, meaning those who were given HRT versus those who were not given HRT. Now, two recent meta-analyses, which are both or were both published in 2016, showed no association between post-treatment MHT and risk of ovarian cancer recurrence, though significant methodological limitations in the included studies necessitate confirmation of the findings. And there are no data on the safety of the use of MHT after treatment for granulosa cell tumors. However, MHT is generally avoided as these tumors are frequently hormonally active. The use of MHT in more rare types of ovarian tumors have less strong evidence. Endometrial ovarian cancer is sensitive to estrogen, and thus avoidance of HRT is often suggested. Although there is no direct evidence to prove or disprove the long-term negative effect of HRT on granulosa cell tumor survivors, considering the hormonally endocrinologically active character of these tumors, it may be safer not to initiate HRT in these patients. So what are the clinical pearls that we have learned for MHT after ovarian cancer? So limited data suggests that MHT may be considered as indicated in women with epithelial ovarian cancer. However, for women with advanced endometrioid adenocarcinoma of the ovary who may have residual disease that is hormone sensitive, MHT should be avoided. MHT should be avoided after granulosa cell tumors, though substantive data are lacking. We move on now to cervical cancer. The majority of cervical cancers relate to persistent infection with human papillomavirus or HPV, with 70% of malignancies caused by type 16 and 18. Approximately 80% of cervical cancers are squamous cell carcinoma, and the majority of the remainder is adenocarcinoma. How about hormonal influence for cervical cancer? Squamous cell carcinomas of the cervix are not considered hormone dependent. Now, some studies regarding MHT use and the risk of cervical cancer have shown no association or even a decreased risk, while others have shown an association with adenocarcinoma and either no association or decreased risk with squamous cell carcinomas. This is a fairly old study that looked into the hormonal replacement therapy use for patients after cervical cancer treatment, and it showed that there's no significant difference in the recurrence risk or survival between the two treatment arms, meaning those who were given MHT versus those who were not given MHT. In addition, MHT group had better control of climacteric symptoms and relief of radiation-related bladder, rectal, and vaginal symptoms. So the clinical pearls that we learned for the use of MHT after cervical cancer are the following. HRT is not contraindicated after treatment for squamous cell carcinoma of the cervix or adenocarcinoma of the cervix. Squamous cell cervical cancers are not hormone dependent, and therefore MHT can be used as indicated. And lastly, we talk about vulvar and vaginal cancer. Vulvar and vaginal cancers are quite rare, and they account for only 6 to 7% of all gynecologic cancers. Squamous cell carcinomas are the most common type of vulvar and vaginal cancers, and most are HPV related, just like what we learned about cervical cancer. Adenocarcinomas of the vulva may arise from Bartholin's glands and are much less common. As for the hormonal influence of vulvar and vaginal cancer, squamous cell carcinomas of the vulva and vagina are largely HPV related and are not hormone dependent. There are no data that suggest harm with the use of MHT, and because adenocarcinomas of the vulva and vagina are quite rare, there is a positive data regarding hormonal influences. So, clinical pearls regarding MHT use after vaginal and vulvar cancer are the following. MHT following treatment for squamous cell vulvar or vaginal carcinomas can be used as indicated for menopausal symptoms, as these tumors are not hormone dependent and there are no data to inform decision making about adenocarcinomas of the vulva or vagina. So that's it for my lecture. So in summary, we have the following. MHT is not recommended for use in breast cancer survivors. Non-hormonal options for menopausal symptoms are advised. Limited data suggests that MHT can be used in women with low-grade, early-stage type 1 endometrial cancer, epithelial ovarian cancer, and germ cell tumors. MHT should be avoided among women with advanced endometrial carcinoma, endometrioid adenocarcinoma of the ovary, and granulosa cell tumors. Squamous cell carcinoma of the cervix, vagina, and vulva are not hormone dependent, and MHT can be used. Low-dose local vaginal estrogen therapy may be an option for treatment of vaginal dryness related to hormone deficiency after certain types of cancers, even if systemic MHT is not recommended. So this is the end of my lecture, and thank you for watching this video.